Welcome, everybody. Thank you for tuning in. You are watching School Psych Podcast. My name is Rachel. I'm a school psychologist in Maryland. Really excited for our guest tonight. I saw him present. He came and presented to my county and super knowledgeable and just really good practical things and not afraid to kind of tell it like it is. So I really enjoyed the presentation, and I'm sure that everybody will as well. And we've not done psychiatry and medications and whatnot on the podcast before, so I think this will be a really good one. But I'm going to pass it over to Rebecca, who's going to talk about how to participate tonight. Rebecca.
Hello, everybody, and welcome. We're so excited to have you join us for this episode. If you are watching live, please do join in the live chat right alongside your YouTube video. You have to be logged in to your YouTube account, but once you're logged in, you can comment right alongside the video. And even if you're not watching in real time, if you're watching late and with a delay or on another day, you can still comment, and those comments get synced up. We will see them and we can respond and have a conversation over time. We'd love to know your questions and your experiences and your thoughts as we go along. And there are other places where you can message us and comment as well. I would love to hear from everybody. How do you follow Psyched Podcast? Do you mostly follow through YouTube notifications, or are you mostly listening on iTunes or Spotify in the audio only? Let us know in a comment sometime this week. I would love to know. But if you're following along, you saw the tweet for the podcast episode. Please feel free to tweet at us at Podcast Psyched on Twitter or X or whatever you'd like to call it these days. You can also message us, either an inbox message on Facebook or right alongside the post for the event for tonight's podcast. And you can use the hashtag Psyched Podcast in both places. I'll be looking for notifications. So if you are tweeting or messaging along, we'll bring that into the conversation if you'd like us to. And then lastly, I did post also on Instagram. And I'm wondering, because I got a lot of hearts, a lot of love for the post in my story, let me know if you're mostly following along on Instagram. We'd like to be where you are and make sure that you are aware of our wonderful guests and episodes and involved in the conversation. So thank you so much. I look forward to hearing from you. And now I'm going to hand it off to Eric, who's going to introduce himself and our wonderful guest.
Wonderful. Thank you, Rebecca. Well, we're excited to have Dr. Jeff Bostic with us this evening. And he is a child psychiatrist in the Maryland, D.C. area, and is currently a faculty at Georgetown University Hospital, and is active in the intake clinic and consultation program to primary care clinicians and consultation to local DC schools. He also remains affiliated with Harvard Mass General Hospital, where he was the director of school psychiatry from 97 to 2016. And Dr. Bostic remains active on the American Academy of Child and Adolescent Psychiatry committees for schools and continuing medical education, and an assistant editor of their journal. He recently spoke, and Rachel had the opportunity to hear him, and we all got excited because Rachel was telling us about Dr. Bostic and that it was interesting and engaging, but also so many things that as school psychologists, we might only have a cursory awareness of, or we might even have a little mythology perhaps into the medical field and psychiatry. So we welcome you, Dr. Bostic, and are excited to hear about collaborating with psychiatrists and working closely with medical field professionals in schools.
Thank you, Eric. I really appreciate that very kind introduction. So thank you. In the spirit of full disclosure, a couple of things I should just acknowledge. First, I'm required to tell you if you ask me anything about like commercial properties or purposes, that if I have any relationship to that. I don't think anything will come up like that, but I'll be glad to try to describe that if they do. So there's no conflicts that I can think of surrounding this. Indeed, I was a faculty member at Georgetown, but I've just retired. I still have a little bit of work that I do with them, but I wouldn't want you to look me up and go, wait a minute, we don't see him here. Is he a fraud? It's just a growing older kind of thing. Similarly, I still do continue my work with people back at Mass General in Boston and Harvard and so forth. And currently, I also have an affiliation still with the University of Maryland, and I do work for the State Department of Education. However, it's important for me to clarify that nothing that I say should be taken as representative of a statement or policy preference from the Maryland State Department of Education. So they made me say that so that you would know that this is me speaking openly with you about this and not representing any other kind of entity.
Thank you. That's important. Well, I think probably the first thing that comes to a lot of our minds, because behavior issues are, one of the top things that school psychologists deal with and educators. Talk to us perhaps, about medication, ADHD, what's kind of current. And we were having a really enjoyable conversation before we went live here about some of this stuff. So what's new and what's going on in this part of the field?
Well, obviously, that's a great question, Eric. So the funniest part of this is I'm going to say some things that many of you are going to go like, oh my gosh, I can't believe you would be such a heretic about some of these things. But it's the virtue of like watching some kind of like trends go on during one decade of your life and then a different trend, as the pendulum swings from one side to the other and the next. So here are kind of the big things that I'm observing at this point as I'm closer to the end of my career than the beginning. I think we had really good intentions way back to say, wait a minute, let's get really specific about what is causing Hubert to have an explosion in the classroom versus Henrietta. What are the distinctions? And so with DSM, right, we have all these diagnostic codes and things out there for all these disorders, but we have no biological proof of any of them. There's no like, oh, this is the gene associated with this disorder, and this is the treatment that will fix it. Even our most effective, quote unquote, medicines, like the stimulants, and again, Ritalin, methylphenidate, Adderall, amphetamine, those two kind of agents, I mean, there's not a lot out beyond them, and they've been around since really they were first discovered in the 1930s. And so really all we've done since then to make them better is make them like dissolve more slowly so that they will last longer in a person's system or something like that. But most importantly, they don't cure you of ADHD. You don't take these for a span of time and then, now once you stop them, you're all better. Unless during the time that you're on them and your focus might be increased a little bit. In that case, if we teach you like how to like work better, to like remember things with your working memory, or to remember routines, or to have cognitive flexibility, like one of the biggest predictors of happiness on the planet is being able to be flexible. And we all see kids who really struggle with that. And to deal with interference, right? We start thinking about something like how to solve a math problem. And my example is always like, whenever we have to take our recertification exams, which I'm sure you guys do as well, I always get to about the third question. It's like, wait a minute, I don't know this. And instead of just figuring out the answer, like what could this be, whether it's A, B, C, or D, I'm like, how can I not know this? I know that they told me this back in medical school. I know I've seen this before. Oh my God, I'm probably getting demented or something else is wrong. Maybe I have a brain tumor. And I just go off into the seventh level of hell, if you will, thinking about other things. And we all do that, right? We have quote unquote cognitive interference. So there's all these specific things that we try to teach kids to do or need to teach kids to do to actually contend with quote unquote inattention. There's a bunch of components to that we really need to work on. So anyhow, the point of the story is, now we have all these different categories, and you probably remember even 10 or 15 years ago, it was like, oh, I only have ADD. I don't have ADHD because I'm not hyperactive. And all that did was confuse people. And so the reality is now it's all ADHD, right? It's like inattentive or hyperactive or combined type, et cetera. And the whole point is like, we act like these things are discrete things that people have or don't have. And the reality is, in our day and age, pretty much most of us feel like we have ADHD. And the thing is, we probably all fit somewhere on the spectrum of these things. And the issue is how impairing they are. And can we optimize the environment for an individual human being, particularly at school, to dissuade the impact of like difficulties with inattention or hyperactivity and so forth and so on. So the whole point of the story is that we're probably all on the spectrum somewhere for ADHD. And again, some of us, it doesn't bother us much and we do fine with that. All of us struggle to some degree with mood regulation. That is, there's times when we feel sad. There's times when we feel nervous. It's good if you feel anxious. It keeps you from like free solo climbing and doing stuff that may not be in your best self-interest. So a little anxiety is good, but we also know kids and our friends who sometimes have too much of that, right? And so the whole point is you can look at like executive functioning skills / ADHD is like one spectrum. You can look at also, like, again, mood regulation. Where do you fit on that? Where do you fit on conflict negotiation and getting along with other people? Things where oppositional defiant disorder and conduct disorder historically have been. But when people get rigid and they can't seem to like come to like resolution on things. And then the fourth category, the fourth spectrum for me is social pragmatics. And I apologize. I appreciate that you're going to look at, isn't that like most males walking the planet? We are missing half a chromosome, all right? So we got a little bit of a disadvantage. But the point is, pretty much a lot of people need help with social pragmatic stuff to a degree, but that doesn't mean that they necessarily fit, quote, far over on the end of the quote unquote autism spectrum. So the point of the story is I'm wishing selfishly to see that we move not so much more to having increasing numbers of DSM-6 or DSM-8 categories, but instead to go, wait a minute, it's not unusual for people to have like times in their life where they struggle with this stuff when the environmental demands may get greater, and then we need to do something to kind of ameliorate this. But this is not something that saddles you for the rest of your life. And that's one of the things that's been specifically hard about this is most of the mental health conditions arise by the age of 18. Even serious things like bipolar disorder and schizophrenia typically will start to show up again around 16, 17, 18, although they may not fully develop until a little bit later on. But that's pretty different than pretty much every other disease category that we know about. You don't typically get even like musculoskeletal syndromes until you're a little bit later in life. And again, we're talking not genetic syndromes here, but other things, diabetes and things, unless you're born with it and you're missing insulin, but other people, they don't get that again until they're older. So our kids in our field, we're the ones who spot them and see them first. And so they grow up with like, oh my God, this is a part of my identity. And so it's so important that we don't let this be something that makes them think they can't do stuff, because they will be able to do stuff. It's like we all learn how to live with some degree of ADHD, with some degree of like mood distress, some degree of like, some kind of people will make it hard for me to like negotiate and get along with them. And sometimes my social skills work well in one place, not so much in another place. All right, I'll cease to desist there for a second. Any thoughts or comments?
Yes, there's so much in what you said that I wanted to ask you a question about. But generally, as you were talking about kind of this, the diagnostic categories in the DSM-5, and it made me think of how the DSM-4 had that multi-axis system, like the different axes, and they took that out. And I wonder if you feel like they lost something by doing that. And then my second question, just to add to that, is, do psychiatrists, are you also looking at like symptoms and symptom counts? And are you saying that you make diagnoses largely based on level of impairment? Is that how you do it?
Those are a bunch of good questions, Rebecca. So the first thing is I've watched the evolution of DSM over time. And so the point is that changes, it morphs all the time. And there are, of course, very conspicuous historical things about what was considered a disorder in past decades. Homosexuality, for example. Similarly, there was good intentions of like trying to like measure global, assessment of functioning for people in circumstances like that have kind of been moved down in terms of their priority now with the changes from DSM-4 to DSM-5 and so forth and so on. And the point is to like, this is the most important thing. Moses is truly not sitting in the corner of the room adjacent to a burning bush and going, oh my goodness, finally I've got the 10 tablets. And it turns out these are the actual conditions that are going to impair human beings. It's like we make this stuff up as best we can to like look at things that happen to human beings based on symptoms. We don't have good enough brain science yet. MRIs, functional MRIs, the whole SPECT scans, all that kind of stuff, to definitively go in and say, here's exactly where the problem is for a psychiatric condition, and here's how we're going to ablate that pathway, morph that pathway, and change brain chemistry. And again, probably the funniest example of the brain chemistry thing is the neurotransmitters, right? Oh, if you have problems with anxiety or depression, you have too low a level of serotonin. Well, that's turns out to not be true at all. There's a great study that came out about a year or so back by a woman named Moncrief in England. And the whole point was they looked at all of the things that surrounded that theory that, oh, if you have a low level of serotonin, that you would be more likely to have depression. No, they looked at all the things that were the precursor chemicals that led to serotonin. Oh, you don't have enough tryptophan. That's what's actually causing it. None of that stuff turned out to be relevant, nor the few genes that we know that are associated with it. So here's my funny story. When I went to medical school back in 1988 or so, there were 4 neurotransmitters. Okay. Now there's about 200. And my smart friends are like, those 4 things we thought were neurotransmitters, we don't even think they're neurotransmitters. We think they modulate the other major ones, which right now the major neurotransmitters this week are glutamate, the excitatory one, glycine and GABA. The latter two, glycine and GABA, kind of slow things down. They're inhibitory kind of things. And the other ones just kind of affect that. And you're like, but wait a minute, Boz. I know people who have been placed on fluoxetine, Prozac, escitalopram, Lexapro, or sertraline, Zoloft, agents like that. And it's like, and they got better. We're not denying that. But the whole point is that there are a bunch of other things that also increase the levels of chemicals that we think are more important. So here's the funny part. Back in the 90s, I worked with a guy named Trivedi, who's a great neuroscientist, not a child, but an adult psychiatrist down in Dallas, Texas. And we were giving people down there things to actually stimulate the production of things like serotonin. And we found that even when you did that, they didn't get any better. It really didn't fix anything, right? So we're like, yeah, we have to figure out something else. The point of the story really is that we learned that it wasn't serotonin, for example, that was the issue with people, but rather something that serotonin perturbated or fixed, which in our case is brain-derived neurotropic factor, BDNF. So the money right now is looking at agents, medicines, if you will, that we're going to hopefully create or get more specific to turn on BDNF, because that's what really makes a big difference. The old drugs for depression, what are called the tricyclic antidepressants, they work on a different one of those brain chemicals, not serotonin, but one called norepinephrine. They made people like also less anxious and less depressed, but oh, that's right, it was the same common pathway. They both turned on, activated the genes for brain-derived neurotropic factor, and you'd make more brain cells. And that was awesome. And that explained why it would take weeks before you would get better on these agents, is because you had to have enough BDNF to make enough new brain cells that you were able to like learn stuff and replace these frankly dysfunctional Aaron Beck, cognitive distorted, cataclysmic thinking kind of like ruts and pathways that you kind of burned along the way. So we're really looking, I think, at a more sophisticated way of trying to understand this stuff. And this is where it gets real practical and concrete. So we know that the serotonergic drugs, the ones I mentioned a moment ago, Prozac, Zoloft, Lexapro, Celexa, the ones like that, they do increase serotonin, which does turn up BDNF. Okay, cool. We want something that's more precise, so we'll have less side effects. Because it also affects your libido. It also affects your sexual functioning, all that. So it's not real specific, which is a reason that you want something, more specific down the road. But the bigger thing is to see if we can find something that will do that, again, bypassing those side effects, and that'll work more directly. Right now, we don't have a medicine specifically for that. And here's why I'm chuckling. Exercise turns on BDNF. Human beings are designed to walk around and be active. And this is what's changed. It used to be that it was like, oh, no, you only can do aerobic exercise, right? Jogging, walking, those are the only things that help. No, you can lift weights. You can walk around. Anything that you do, it turns up BDNF and will help your body both physiologically increase stamina, but also psychologically, again, keep BDNF up so that you're regenerating new neurons to function effectively as you continue to grow and change. Was that long-winded enough, Rebecca?
That was amazing. Yes, thank you so much. I love it. I'm not going to hog all the questions, so I know Rachel has one.
No, I could have a million, but it's so interesting though that all this complicated things, and then it's like exercise and all these things. But it's beautiful. When you were talking about, first off, I was just thinking back to past podcasts where we've had guests on that lament about not having a cut point for certain things. That how low do you have to be to have dyslexia? Like, okay, so a kid that has an 84 versus a kid that has an 85. Like, what's the functional difference between those two? That these types of conditions you can't really have a cut point, and it seems like these psychiatric conditions in the DSM, they're saying 6 out of 9 symptoms across 2 settings. So they're making these, but it sounds like what you're saying is, these are arbitrary. It's more kind of a spectrum thing. So that just that connection to other podcasts. So I think that holds across mental illness and learning and just most anything human. It's like to have a set black and white thing is just not how we work, right? But I had a question too about when you said that there's no biological difference between any of these disorders. I hear a lot and I see a lot on social media about people with ADHD have a different size, whatever, in the brain, or people with, that these scans can show that they have less gray matter here or that type of thing. So what is that coming from? Is that just because that's so much data and not an individual, or where are we seeing, or am I just getting these things that I see on social media? Are they just total nonsense?
No, and I apologize. I'm not suggesting that there's not biological differences between people who have greater and lesser degrees of various symptoms, whether they're physical things like what kind of food they can tolerate, or whether it's psychological stuff, all the stuff that fits within our domain. The problem, in my experience, in my observation over time, has been that we have just not stumbled upon the correct ones. Eventually, if God answers my prayers the way I want her to, we will find out that there is this culprit. And the funny part of this is that 200 years ago, people would talk. Well, 300 years ago, people would talk about bleeding people, right, to get the evil, wicked humors out of them, right? It was like, oh, you got too much phlegm or whatever, right? And now it's like, what were they thinking? Our kids, let alone grandkids, are going to be, I don't know what you were thinking, Dad, Grandpa. And that's the whole point. Is it's like, it was like the serotonin thing. Ah, ha, ha. That was really a funny thing, but it was better understanding we had than some of the things that preceded it, and some of the particularly bizarre things. And I'm going to pay homage here to the most unlikely person. Freud wasn't a crazy guy, but he was like anything in science. It's not all going to be right. It's not religion, if you will, where if you do have some lucky direct connection to some cosmic presence or whatever, that's great. But the reality of science is they're always taking 2 steps forward and 1 step aside and going, this worked and that didn't work. The best example, by the way, as I allude to antibiotics, is the first antibiotic was created by a guy that nobody ever talks about because he was a German, and it was during World War II. And so I was like, ooh, this is not like a good thing to talk about. The guy wasn't a Nazi. He got the Nobel Prize, but he couldn't go to Stockholm to receive it. His name was Gerhard Domach. And the whole point of the story is that he stumbled upon this and he said, oh, I think that what really is helpful in this particular medicine is that a particular group on it, a dye, if you will, is actually what kills bacteria. No. The French figured out that he had it all backwards, that it was actually the, quote, sulfa drug, the sulfur part of that compound, that actually was effective. And so other people kind of figured out that. So analogously, throughout, whether it's DSM-4 or whether it's serotonin or whether it's whatever, it's like this stuff is always in a state of evolution. And my aspirations are that there will be a time when we will be able to go in and do something immediately or quickly, efficiently to specific parts of the brain in some kind of fashion where we don't harm it and other parts of the brain, where we can deal with things specifically like OCD, specifically with things like schizophrenia and bipolar disorder, which in my opinion, they're very real things. The diagnoses and whether you need 6 criteria or 4 or 3 or whatever, that's kind of made up, right? But the whole point is that those are pretty real phenomena that we kind of see. So I like to believe that down the road we'll have that, but we don't have it right now this week. And so I'm just mindful that we think about that when we're going forward. So here's the point. There's actually a point to this long-winded story. And that is what I'm seeing, kids, which is what I do most of the days of my week. I don't focus so much on, well, do I really think this is bipolar disorder, or could this be really disruptive mood dysregulation disorder, or maybe it's just MDD not otherwise specified. That's not really where the money is. The money for me is, what are the symptoms that are truly interfering with this particular kid's functioning? And then concretely, it's like, if it's just in one place, school, for example, or at home, I'm like, what are we going to do at school or at home to kind of fix that? And we're still going to focus on that kind of regardless. But then in addition to that, if we find that this stuff is cutting across a lot of different things, then obviously we want to be more aggressive with our interventions. So that, again, we're doing stuff that will help them function in a number of settings. So the entire point of the story is, I'm much more selfishly preoccupied with what are the most important symptoms impacting a kid. And here's the big truth. This is a Rebecca-ism. I'm going to blame this on her because we were talking right before we came live here on this. And it's like, well, what about ADHD versus kids who have, maybe anxiety? It's like, of course they overlap. And the truth is that, like, giving you a diagnosis of whatever, ADHD, depression, whatever it might be, it doesn't inoculate you from having symptoms of any and all other kinds of mental things. And so it's not so much that, well, ADHD is the main thing, and then we're going to like prioritize anxiety after we do this. It's like, no, it may be 3 symptoms of ADHD that we're going to go hardcore on right now, and 2 more symptoms of anxiety. And here's the reason I'm telling you this. You work in the best place ever to bring that about. It's this place called school. You get 15,000 hours to work with kids between like kindergarten to 12th grade. That's a lot of time to like really focus efforts and personalize experiences for kids to pull for the best that the brain has while it's still plastic and while they're still young. So again, focusing on what are the symptoms that are, actually impairing a kid is really where the money is in my mind, rather than people arguing about whether or not they have 3 symptoms of that or 9 symptoms of that, and therefore we're going to put them in this classroom or that program. It's like, are we really thinking about the individual kid here? Is kind of the way to go.
That's awesome. And when we talk about, learning and, teaching a kid to learn to read, you hear the debates. Is it a learning disability? Is it what is it exactly, when sometimes the most appropriate thing is to figure out what aspects of learning, what do we need to remediate? Is phonemic awareness, the decoding, is it whatever? So just seeing that. I had a question about, we talked a little bit before we got on the program about the effect sizes of medications and things of that. Can you speak to that?
Yeah, but it isn't pretty. So the whole point of this story is really in the last couple of years, right? Everything now is about quote unquote meta-analyses, right? Let's take a whole bunch of studies that have occurred over a long interval of time, find a way to combine those studies and look at what they collectively represent. And so, of course, again, you guys know more about the statistical modeling of much of this than I do. But the reality is that with meta-analyses, you look at effect size. And the advantage of that is it allows you to look at studies that are very different in terms of the number of subjects and so forth, but make them where you can integrate them and then they're comparable. All right. And so here's the funny part. It turns out that when you have an effect size of about 0.6, that's pretty good. That's like being able to distinguish, if you were to look at 2 people, a 14-year-old and an 18-year-old. Most of us would go like, I'll lay some money on that. I bet I can look here and most of the time pick the 16-year-old compared to like the 12-year-old or the 18 versus the 14. Unfortunately, when we start looking at a lot of our drug stuff, and specifically, for example, like the antidepressant stuff, the effect size is about 0.2. That's like trying to distinguish a 14-year-old from a 15-year-old in terms of the difference, in terms of how big the effect is for this. And that's like, I don't have a whole lot of confidence in that. And I say that not to mean this. Some people are like, so you're saying we should never use like the SSRIs or any of these things? No. And for some people, they're enough to help them round the corner and do better. But you just got to be mindful that it's not going to be a profound difference necessarily that you see on these. And therefore, who is not going to benefit from cognitive behavioral therapy in this lifetime? I mean, you're going to have to point out to me the contraindication to that. Everybody, I'll even speak for myself here, has days when they wake up and they're like, we're kind of down and we have some dysfunctional thoughts, negative thoughts, etc. And the point is, having CBT tools is very helpful. DBT, dialectical behavior therapy. Yeah, it's helpful to like learn how to spread my fingers far apart and then like relax them. When I can't use like verbal stuff to talk my stuff down as well. The whole point is there's a number of therapeutic modalities here that I wish ever more to become mental health literacy within our schools, and kids use them from the early ages on so that they'll be less likely to increase the magnitude or the severity of their symptoms with that. I do want to mention the other funny thing, which is our benefits and our effects for the stimulants, right? For ADHD is better, thankfully, right? But the jokes, there's a couple of jokes that no one ever tells you about. And they're worth knowing because you're going to get saddled with these. People are going to come and ask you about this. Shouldn't Hubert just be on a stimulant medicine for his ADHD? I've been involved with a number of ADHD studies over the course of my lifetime. And typically you give someone the Vanderbilt scale or the ADHD scale, right? And you look at that, and if they have, right, 6 of 9 symptoms, like there's some magic there between. If you don't have 5, oh, thank God, you're okay. No, but it's like somewhere in there. If you have a number of symptoms and the score is high enough, then they say, yep, it's impairing enough that you have ADHD, and therefore we're going to randomize you to the medicine or placebo. Okay, fine. But then here's the funny part. What do you have to do to get better? Well, you don't have to get like 100% better. You only need to get about 30% better. So that means if your symptoms go from every day they whack you and they impair you and harm you to like, well, only 3 to 5 days a week they whack or impair you for all these same symptoms, that's a 30% improvement. Well, I aspire for a little bit more. So again, the point of the story being that when we do the pharmacological studies, sometimes they're helpful even with the agents that we think work quickly and make a difference. The stimulants is like, right away. There's none of this BDNF stuff going on that takes 2 weeks before you see a benefit. It works immediately. Now, let me say the bad thing about this. Some of you may have majored in recreational pharmacology when you're in college. Just saying, okay? And the reality is that you didn't have to have ADHD to notice that those medicines actually allowed you to focus and concentrate a little bit longer. So you should know that these drugs are also very politically relevant. And I'm going to be real uber concrete again. And again, I hope it doesn't sound like I'm bashing on any one nationality, because I don't mean to do that. But if things are just sticking out there, then you kind of do it. The stimulant medicines were discovered by a guy named Charles Bradley, actually in the United States, who was using them with kids again who had like meningitis and had like serious like neurodevelopmental brain injuries. He was trying to just get them better from having headaches and stuff. And he was like, their headaches aren't all that much better, but my God, they're paying attention for longer periods of time and they're focusing, right? So it was kind of like a serendipitous discovery. 1937. By 1941, the United States was involved in a war with these people across the big pond, as they say, the Atlantic. The Germans had been using stimulant medicines for their entire army, like starting in 1939, 1940. And so you didn't have to have ADHD to be able to focus longer, sustain interest, and all that kind of stuff. And that's been known, again, since 1940 or so. So these things have often been used. And you're like, well, was that such a bad thing? The good intention of that really was that pilots specifically would be able to not fall asleep when they were coming back from flying a plane and crash the plane, et cetera, et cetera. But then it was everybody driving a tank. They gave it to the German women because it decreased their appetite. So when food got scarce in supply, they wouldn't be as hungry. I mean, it's all kind of like weird political stuff that was relevant to this. And then the craziest story probably of all is Hitler, right, was taking this stuff every day. There was a, quote, Dr. Feelgood guy that would inject him every day with all kinds of stuff, including amphetamine. And he literally burned out the middle part of his brain, the substantia nigra, that's associated with some movement stuff. And that caused him to have a tremor where he would like roll his fingers. If you don't believe me, that's okay. You can Google video on Hitler in 1944. The one that I saw was where he's literally talking to like young boys that are about to go, Hitler youth that are about to join the military. And he keeps his arm behind his back and you can see it going on. So he was receiving way more of this than he should be. Of course, it made him, there were some deleterious side effects to that. But in addition, physiologically, it really came at a huge kind of cost. So I'm not saying that stimulants are bad. I'm simply saying you got to be mindful of those. And they're still not going to replace the hard work of going in and working on, do you know how to use mnemonics? Because that's one of the ways that you can actually improve like your ability to remember things, which if you can't remember stuff, then trying to use it over and over again in different situations flexibly, that's not really going to be very doable. So the medicines, again, have a place, but I just want to be mindful about what their real place is in real life.
So are you saying that the stimulant medication for ADHD would help anyone, regardless of where they are on that ADHD spectrum, focus?
Here we go. Here's the hook. She's gonna hook me here and go with the bait. The reality is not quite. The truth is that most people on the bell curve would notice that they are less likely to need as much sleep, and they are more likely to say, wow, I focused a little bit better than I did without the medicine. However, all of us are on the spectrum, right? And the whole point of the story is that for plenty of people who are more on that anxious spectrum than disorganized inattention, kind of spectrum, can make them more rigid, can make it where they're absolutely unable to do stuff and they're rigid as a rock. Worse than that, these medicines trigger a neurotransmitter, neuromodulator, I'll call it now, called dopamine, right? They increase that. Well, that's one of the things that goes up that you see with schizophrenia and psychotic thinking. Now, the whole point of the story is you're like, well, wait a minute, don't we give people medicines to stop that? We give medicines that will reduce your delusions and your hallucinations and things like that when you have bipolar disorder and have a psychotic episode, or even depression and have psychosis symptoms or whatever. But the point is like those people are probably more vulnerable to the negative effects of stimulants than other people. So we have to be very thoughtful about, again, the individual. And this particular person in their constellation of symptoms may say, whoa, they might benefit from a certain medicine that would be absolutely unhelpful to another person. Same as giving you blood pressure medicine would be. If you have low blood pressure medicine and I give you an anti-hyper, a blood medicine to lower that, obviously that's going to make things worse instead of better. So it depends on where you fit on these various spectra for those kinds of decisions.
I think that's really important, especially because I do happen to know a lot of college kids who would major in psychopharmacology if it was a free pass to focus and better grades or whatever.
Well, it's a huge deal, and here's where it's a huge deal. In 2005, Major League Baseball looked up and said it really would be good if the players didn't all have an Elvis Dr. Feelgood doctor giving them these kind of medicines. And so they said, enough, we're putting a stop to this. And they did. And the way they did that was they had people go in and evaluate people more carefully. Now, as you would imagine, some people who were used to doing this is part of their routine. It's the thing that works for them. They were like not eager to say, oh, thank goodness I don't really have ADHD. Here, take all my amphetamine back, and I'm glad to know that I'm good now. That's not what happened. What happened was some of the players didn't really have ADHD, didn't meet criteria for that, didn't really manifest that like over their course of their life for years and stuff like that. But the solution to that was not to say, you don't have it. The solution to that was go, wait a minute, what's really going on here? Anxiety can cause you to have inattention kind of symptoms. And let's just see, if you're standing out in front of, let's just say 30,000 people, and you're supposed to hit a ball and get to first base or whatever, and you don't do that 1 out of 3 times, then you may not be there next week. So it's like there was a lot of stuff that would compete with your attention in there that wasn't necessarily, quote unquote, really more on that ADHD spectrum, but on this other thing. So what happened? Efforts were made to help all these players again with like ways to manage their anxiety, to stay focused and stuff like that. And I'm going to proudly say that I'm not saying this about one esoteric ball club in Major League Baseball. All of the Major League Baseball teams now have a person who evaluates people that believe they have ADHD or who come into baseball with diagnoses of ADHD and or medicines and stuff. This is important for 2 reasons. One is it's spread. That is not the use of amphetamines and stuff, but the use of actually getting good, clear diagnosis and figuring out what stuff really is rather than some simple, like just chunk of medicine at them solution that might have happened when they were way younger. But also the stigma. I have seen destigmatization go on in such a huge degree by watching like people who've been much more open about this stuff, whether it's been pro athletes, whether it's been, again, celebrities and stuff like that. Back, 20 years ago, literally, we wrote a paper about young people who had been open about their psychiatric, diagnoses that we could then share about with kids. So it's like, it's not a big deal if you have bipolar disorder, OCD, whatever, so-and-so did. And this is how they managed it and stuff. So it was a way to make these things less scary. They wanted us to revise that paper. This was probably 10 years ago. And we were like, okay. And we looked up and the number had gone from about 65 people that had written about it, talked about it. We had good information out there where we weren't betraying anything, to over 300. There was no way we could kind of keep pace with it. So the whole point is that people get it. And the bigger thing that I'm trying to say here is baseball players, for example, weren't mentally ill. It was that they had symptoms like other people. And just as they worked on their nutrition, just as they work on all kind of routines physically to get good at stuff, of course you work on your mental stuff to get better on that as well. So I'll tell you one quick funny anecdote of this too that you'll like, I hope. Music. It turned out in 1912, cyclists figured out, this is the way they figured it out actually. In New York City, there was a bike race that was going on, and they looked up and it was like in one area, and it wasn't the same area like geographically, like this block or that block. It was instead, they found at certain times that certain people were like, they were pedaling faster. I'm like, what the hey? And it turned out that was where they were in a certain proximity to the marching bands that were walking through there. And so when they were hearing music, they would get in cadence with that and they would go faster, about 10 to 15% faster than they normally would. So since that time, athletes are notorious, as you can watch them coming out of the tunnels with their AirPods in, listening to music to fire themselves up, get themselves in a good groove. So much so that this is my favorite part. The Boston Marathon folks decided in the 1980s, is like, no more of this. This is not a fair advantage for other people. We are like banning people from wearing stuff where they can like listen to music when they run the Boston Marathon. And what did the Boston Marathoners who were serious do? They got all their friends to get on the building tops all along the course and use their boom boxes to play the music that they needed at specific times so that they could do that. So obviously that effort failed. And the entire point is simply that music, for example, is an incredibly effective performance enhancing thing for all of us. And I don't mean performance enhancing in a negative connotative kind of way, but rather in a positive way. It's like, it's a healthy thing. Most people like music. 4% of the human beings on the planet can't really distinguish music, and it's annoying to them, but 96% of us do. We release oxytocin when we hear it, or dopamine, oxytocin more when we're in concerts and around other people. But it's, again, something that we've really kind of like not taken advantage of enough in school settings, where it can really be helpful for kids, specifically if they've had trauma, because they're so hyper vigilant sometimes that the ambient noise disrupts them constantly from being able to study. Another thing that causes people to have inattention, right? Versus just like typical ADHD kind of stuff. So there's a bunch of things like that that I think we can continue to coalesce and harness when we're like working in a school building, that are practices that are what we really want people to do for the rest of their life, rather than, can I take this medicine now for the next 40 years? So
that's such good stuff. And I was thinking about the Boston Marathon. I remember that rule that you couldn't even run a qualifying race with headphones on, and I just never understood that. So now I do. I had a question, and it may be somewhat tangential, maybe, but I'm sure you're familiar with the ACE study, the Adverse Childhood Experience Study, and how a certain number, or the more adverse childhood experiences one had, the more likely they were to have physical disease in adulthood. And I believe there's some conversation about the main ingredient of some of that disease is inflammation, right? And so what do you think about that? And why does that happen? And is there anything we could do in terms of prevention, or like things that reduce inflammation, or things that we're doing now that increase inflammation?
All right, this is a question that's like right over my head that I cannot answer because I'm too stupid or ignorant to really know the answer. But I can tell you a couple of things as I've watched and read about what other people smarter than me are like trying to do to make sense of this. Just like we're talking about differences between where people fit on the spectrum for attention or anxiety or whatever, it's the same thing with your biome, right? Some people are genetically predisposed to like have more inflammatory kind of responses. Some people to have less so. That's also just like attention, like ADHD and anxiety together. It's just like your biome your gut biome, I'm saying, can also like relate to like other things that you might have. And so the whole point of the story is that we know that, yes, inflammation is typically something that to a degree is good. Oh, something is wrong in a joint, something is wrong in a body part, and you need to like get cells to that area, white blood cells, for example, to combat that illness. Yay, that's a good thing, unless you have too many of them and they're all there huddled together, and then it's like, ow, it hurts, my joint's gotten too big, right? You have too much inflammation. And the same thing in one's gut and frankly in other parts of your brain as well. I think we're trying to get more clarity right now on what are the biomarkers, because we probably know those better in the gut than we do in the brain, because they're just easier to measure typically, so that hopefully we will find some culprits there to do two things. One is to turn down the biome in certain people who need it turned down. And then the second thing is, like you said, to correlate it back to, wait a minute, which of these adverse experiences seem to be the most important? Is it the events themselves? Is it the perception of the event? Is it the duration of the event? There's all these variables that, again, just like right over my head, I don't know that we'll know well, but I do know this. I know that the ACEs was a well-intended, good enterprise to help people recognize the magnitude of how adverse, difficult, traumatic experiences particularly interfere with your life, not just today, but on down the road. And therefore, we need to intervene and do things to stop that for particularly young people, so that they're not continuing to be exposed to, like, getting whacked every day, metaphorically speaking, more so than literally. However, at the same time, I've found 0 people in my lifetime who don't have ACEs, who don't have some score on this, who don't have some trauma. Even if some of us have more of a perceptual, like, I was really mistreated and this was unfair to me, where other people are like, are you kidding me? Nobody was whacking you with a baseball bat. There's differences in this, but our perceptions, I think everybody has their own difficulty in ways that they have to contend with adverse experiences. So here's the big point. One is that having 3 or 4 or 6 on your ACEs questionnaire that you take is not some fatalistic, well, you may get a bigger life insurance policy now because when you get to be 40 or 60 or 80, you're probably going to be dead. It's like, that's not the purpose of this. And we would wish that people not look at ACEs as a fatalistic, you're doomed to kind of thing, but rather as a, wait a minute, you got some things here to be attentive to and to recognize that they could influence your entire body, just as you're saying. So if something's going on weird with you, that may be the way that it's manifesting in you psychosomatically, more so than you look it up and going, oh my God, I suddenly had a recollection of something that happened to me when I was 5 that never had bothered me before. It may come forth psychologically, but it may come forth physically. So I think that's going to be one of the real virtues. Maybe not, maybe it was intended, but of the whole ACEs kind of approach to this stuff.
That's super interesting. And that was a good question, Rebecca. I was like hearing about that. I do want to, and I know we're running out of time. And so I want to be mindful, Eric and Rebecca, if you have stuff too, but I know that we wanted to talk, I think, about how can school psychologists, interact with and consult with and work together with psychiatrists, with medical people? Like, what are some tricks and tips, and what should we be doing to help students?
Okay, I'm just going to be inappropriate, as though we haven't already been down that road a few times. Child psychiatrists, there's only 7,000 of us in the U.S., thereabouts. We're wildly idiosyncratic. Yes, we all get trained with the same sort of curriculum, but it's pretty variable. So I still contend all the time with well-meaning practitioners. It's not just child psychiatrists. It can be pediatricians, family practitioners, nurse practitioners, the whole shebang. The problem is that depending on the state, some clinician with a degree behind their name can write down that Hubert has X and needs some kind of pretty unusual intervention. Probably the most common one that shows up is home tutoring. Hubert has a mitochondrial disorder and needs 3 months of home tutoring. For what it's worth, I really like to keep kids in the game of life, and that means school. And what we know is that when kids are out of school, for example, it's harder for them to sometimes reintegrate. If someone's in the middle of a psychotic episode, you're right. I do not want them to come into school and saying, I think she's trying to kill me. There's times when you don't want the kid there. But for the most part, we do want kids to be engaged there. We do want to find ways to kind of keep them kind of connected there with the school. So very concretely, there's a couple of things that we each do to each other that are our ways to just set the other one off. What you guys do to us, to child psychiatrists, that just makes everybody go like ballistic, is you write us a letter or you send us a note and you say, the meds aren't working. And we're like, what are we supposed to do with that? So what we need is just clarity. And it's not hard. You just say, here are the symptoms that Hubert's having. He falls asleep every morning at 9:30. He wakes up about noon. He's kind of groggy after that. He's gained 14 pounds since we saw him 2 weeks ago. That kind of real concrete stuff is uber helpful for us to like not get all personal about it and who's deciding what, things like that. What we're trying to train child psychiatrists and primary care guys to do and all that kind of stuff is when we do something, here are the big things. We know that it makes you guys crazy when we say, well, Hubert might have ADHD, but this could be the beginning of bipolar disorder. When we have a bunch of quote unquote rule out diagnoses. So we try to like keep people away from doing that. So we continuously say, here's what you do. You say, here are the symptoms that Hubert has. Again, whether it's across those 4 dimensions that I mentioned, the social pragmatics, conflict resolution, or whatever, or if they have disorders. But if you think they have ADHD or whatever, then say you think they have ADHD. Don't go, well, it could be this, it could be that. The other things that really set people off are when we psychiatry people write letters where we say, and Hubert needs, well, my favorite is before we even do any of that, we just send on a prescription pad that Hubert needs full, complete special ed evaluation with IEP, right? And because we put it on a prescription pad, it's like that has some magic kind of thing to it. It's like, that's not our business. We should not be doing that. So the point is, when you see that kind of stuff, we're trying to get our brethren to not do that so much anymore, to instead say, it looks like he could have a learning disability in reading, or it looks like this, but it's up to you guys to kind of like go through that and figure that out. So that's real kind of important also. And then the third thing that we do to really just make you guys like cringe is we say, and Hubert needs to go to pick some school, the such and such school over in such and such place. That's not our business either. Our goal is we can say, well, we think Hubert might benefit from these interventions, and the team can convene and say, yeah, maybe, or no, or we can do this, we can't do that. And that's a much better kind of approach for that. And my final thing that makes me crazy about what we kitty shrinks do, I'm going to be arrogant for a second. I have a doctorate in education. I was a school teacher in Waco. That's why I talk funny, Waco, Texas, right? And so I did teach in a middle school and then a high school for a number of years and did other work in schools. I'm barely familiar with what goes on in schools in the United States. to some degree. Most of my colleagues, not so much. I mean, a lot less than that. And yet it's like, well, I know a little bit about the brain. And so the way that you need to teach this kid is to put a little timer on his desk. And so every time a little sand runs out here, you go over and say, good job, Hubert. And then you flip it over to it again. It's like, you can't do that for a class of 20 or 30 kids. I mean, that would just be chaos and mayhem to do that. But with the best of intentions, sometimes we do things that are off the mark. And so I'm saying this for one reason. We are like trying to provide letters that we work with the schools all the time to like help kind of like get clinicians, mental health clinicians, to like provide information that's actually helpful rather than just creates antagonism and, more importantly, distrust. Once the practitioner on the outside says Hubert needs to go to X school, even if you have a better program, the family's like, wait a minute, my trusted primary care doc since Hubert was born has said this. Oh my gosh, I think I'm getting jerked around or whatever. It's like, it just creates mayhem. So there's a bunch of stuff that we have to do on this to get alignment, I think. And that's really kind of where we are. And here's the hardest part. A lot of times it's unidirectional. It starts with the school, sending letters, doing all this going, and the doctor won't respond to me. They won't respond. They don't do this. They don't do that. That's not unusual. You just have to wear us down. I mean, and so there's good practices to do, and we've tried to put those out there. We've tried to infuse those into the curricula for medical students / child psychiatry trainees. I don't mean, again, this arrogantly, but I've been on the school committee for 20 years, and we've literally tried to provide curriculum to like change these things. And we've tried to write the textbook chapters, across the 3 child psychiatry textbooks to kind of acquaint people with like the approach that would make more sense, and aligning with the school rather than, doing something from the outside that's not really helpful.
I think our audience is probably cheering a collective cheer, right?
Well, we didn't put my address in the thing here, so I don't see any torches outside just yet.
But that's really good, and I think probably from both aspects, we wouldn't want to be telling psychiatrists what to do therapeutically or. Right. And all with good intentions, right? It's not my job to say the medication isn't working. It's my job to say, here's how the child's presenting. So
right. Exactly.
That's really good. Yeah.
That's super helpful. And to be able to tell teachers, because oftentimes teachers are asked to, fill out a Vanderbilt or fill out a comment sheet or something, and that goes with the child to their next appointment to see how they're doing. And I don't know what they're putting on there specifically, but I certainly hear from teachers, it doesn't do anything. It's not working. He needs more. He needs different. He needs this and that.
Well, back to go Erickson on them here. We're trying to get people to just say, this is what we see in the classroom, because the other terrible thing that can happen here is when, I don't mean this in a legal way, it just sounds that way, is when people practice medicine, that it really isn't a good place for them to be. And this, I'm not making this up. This is what you literally see happen. You see a teacher who's just seeing a kid and a family struggle, and the family like, what can we do? And the school person with the best of intentions again will say, oh, my next door neighbor's cousin's girlfriend's badger's mom took such and such medicine and she got better. So it's safe to say if someone with these symptoms, you've known that there are things out there, treatments out there for that, and you should discuss that with your clinician. That's safe ground. And again, if you fail on something, it can be the Vanderbilt, it can be whatever instrument you have accessible and use, and just objectively say, this is what we're seeing. That's uber helpful for people to be like, again, being able to align where it's not someone some friend of mine recommended, or I saw some kid get a whole lot better who was on this. Again, my experience is down the road with the availability of what we have, electronically these days. We're going to be testing kids with all kinds of stuff easily so that we can see where they fit on all these different spectra, not necessarily the 4 that I've suggested, but something like that where we can get real precise with kids. So we don't need to somebody got better that sort of overlapped with it. So let's, do some kind of treatment that really could have much more negative kind of sequelae or side effects than CBT, DBT, things that I really think are going to be much more useful to people than sine and cotangent. Nothing against trigonometry personally.
So interesting. I know that we're short on time, and I want to know if I can scoot one more question in there. And it's a little bit, not necessarily related to what we've been talking about just now, but as a school psychologist, every so often, every couple of years, I get a kid that's sent to me. And, they're seeing things that aren't there. They're hearing things that are not there. And that can be a bit intimidating, a little bit scary, because, you have to think about one procedure wise, like what needs to happen. But you also kind of need to figure out, especially I work with elementary, do they know what they're talking about? Are they describing a dream? Are they just totally faking? Do they have a very active imagination? So what types of things might you recommend? What do you do when you have a kid that presents with possible hallucinations? How do you figure out what's going on?
That's a great question. I'm going to try to answer it real quickly. So the biggest thing is a quick distinction. If it's visual hallucinations, I'm seeing things, there's ghosts in the house or whatever, things like that. Usually that's organic, which is a psychobabbly way of saying, did they take cough medicine the night before? Have they been sick recently with the flu? Do they have other symptoms that could suggest seizures or things like that? You worry about that. Most people who develop quote unquote like schizophrenia, bipolar disorder kind of hallucinations, they're usually auditory. It's usually a group of people that usually doesn't happen until kids are a little bit older, like 12, 13, 14 is when that'll start. And then expect what we just talked about. You write down, this is what the kid described, and then how is it impairing things or not? Are they also getting more paranoid? Are they also getting more distrustful? Are they retreating into their own world? Or are they talking about this more openly and actually connecting with other people around it? I know it sounds weird, but it's not unusual for some people to have cultural components. So like, yes, my grandmother did come and visit and I could see her. And it's like, okay. And if it's not impairing the rest of their life in significant kind of ways, like at school, they can't concentrate. The peers are like, that's okay. But it's like, we don't get too jacked up about it, but do monitor to see if it continues to like escalate. The other quickest thing that's real important to say is all of us have a period of time between going to sleep and waking up where reality is distorted for us. Okay. And the fancy psychobabble terms are hypnopompic and hypnagogic. Hypnagogic is going to sleep. Hypnopompic is when you're waking up. And the point is that sometimes people will say they're hallucinating. Like, well, when I'm lying down, it's in bed, or when I'm lying in the bed in the morning, or when I first get up, and stuff like that. When that's happening, those are usually normal, quote unquote, hallucinations. But again, if they're impairing people, they're causing other kinds of problems with them, with family, with friends, being able to remember academic contact, then it is something again to follow up with and discuss with other folks.
Awesome. Thank you. This has been a great conversation, and I go forever. I feel I want to be mindful of your time and respectful. And so thank you so much for agreeing to spend your time with us. This has been super, super helpful. I want to remind viewers, I think our next podcast would be 121. It looks like we have Dr. Lisa Kelly Vance coming back on for self-care and burnout prevention. Any last thoughts, anybody? Eric, Rebecca?
No, I just want to double down on gratitude. Thank you so much. This has been so helpful and interesting. And I know that our school psych friends out there are really going to appreciate your discussion tonight. Thank you so much.
Yeah, same for me. Thank you.
And back at you, it's so good for me to be able to interact with school people. I mean, you're the people that really do the most work. You've got the 15,000 hours. So what you do makes more of a difference than anything else that anybody else does in 99.99% of the cases. So I'm really grateful for the opportunity to discuss this stuff with you. And if questions come up, please don't hesitate to route stuff to me, and I'll try to figure out somebody who knows the answer to it.
Awesome. Thank you. Good night, everybody.
Good night.